All right. So thank you everybody for joining and welcome. My name is Dr. Anne-Marie Githaga. I am a third-year resident at the Agakhan University Hospital, Nairobi, and I'm a resident in anesthesiology. Thank you all for taking your time to join us in our webinar today. And the topic of discussion today is navigating the new normal in perioperative infection control. We have three able speakers from across Africa. We're going to begin with Dr. David Odaba, and then we'll go to Dr. Christian Kampik, and followed by Dr. Adedapo Adetoye. So again, I'd like to thank Kenya Society of Anesthesiologists for holding these webinars for us. They're very educative, and it gives us a chance to interact during these times. I'd also like to take time to thank all the panelists for joining us today, and to thank all our listeners and all the members of the CANESCA for joining us today. I'd also like to thank our sponsors, AbbVie, who will be hearing from a bit later on in the talk. And I'm going to start on by introducing our first speaker. So our first speaker is Dr. David Odaba. He holds an MBCHB from the University of Nairobi and a Master of Medicine in Anesthesiology at the Agakhan University Hospital, Nairobi, as well as a fellowship in intensive care medicine from North Cumbria University Hospitals in the United Kingdom. He has worked as a resident consultant anesthesiologist and intensivist at Agakhan University Hospital, Kisumu, as well as a clinical fellow in intensive care medicine in the UK. He's currently the program director of the PGME anesthesia program, and also a consultant anesthesiologist at Agakhan University Hospital, Nairobi. He's a member of European Society of Intensive Care Medicine, Critical Care Society of Kenya, as well as the Royal College of Anesthetists and Kenya Society of Anesthesiologists. Karibu, Dr. Odaba.
Thank you, Dr. Gidaiga. Good evening, everyone, and welcome to today's webinar. We are discussing perioperative infection control and prevention in the current pandemic, and I'll try and be brief because there's a lot that we can talk about. Unfortunately, the moderator only allowed me half an hour, so I'll try and fit everything in those 30 minutes. I think from wherever we are tuned in, one way or another, we have been affected by COVID. And I think just before we start, I'll request Dr. Gidaiga to add me 1 minute. And I want us just to take a minute of silence to remember our fallen heroes. These are our colleagues, at least in Kenya, whom we've lost over the last few weeks. And so just take 1 minute kindly and remember them and others that you might know who are our colleagues who have succumbed to COVID-19. Okay, thank you. In today's discussion, there is a lot that we can talk about regarding infection control. Among other things, I'm hoping that when we finish this session, at least we have looked at the infection chain and its importance and how we use it to determine what our interventions are in our attempt to control infection perioperatively. We'll look at what, at least up until today, is the most effective way of preventing infection transmission in healthcare settings, and that is hand hygiene. And then we'll go through perioperative infection prevention with COVID in mind and look at some of the things that we can do to minimize infection. And finally, we'll just have a quick look at what role simulation has in our preparations. I think broadly speaking, I have tried to look at this in terms of preventing infection, both from patient to patient, from patient to practitioner, or healthcare worker, and also from healthcare worker to our patients. So it's not just about protecting ourselves, but it's also about protecting our patients as well as our colleagues at our workplaces. So anesthesia is quite unique in the sense that we are exposed to a wide range of infectious agents. And I think we are among the few professions in healthcare that interact with the whole range of patients. As long as a human being is alive and breathing from the time they are born to the time they close their eyes, at some point they might need an operation. And so as anesthetists, we have the whole range of patients that we have to look after during their journey through the theaters. And so we are likely to be exposed to quite a range of infectious agents, which becomes important when we are looking at the modes of transmission. And as we all know, that for you to be able to actively and effectively control infection or prevent infection, then you have to at least have a basic understanding of the principles. And you can only understand the principles of infection control if you understand how infection is transmitted, and as a result, you are able to intervene or take precautions. Now, these precautions will broadly be classified into two categories. We have the standard precautions, the ones we most refer to as universal precautions, and then we have transmission-based precautions, which just look at the specific modes of transmission and how to minimize or to prevent that from happening. So we'll be looking at all that, albeit in summary, because it's quite a big topic. Now, to start us off, we might start wondering, especially during this pandemic era, why is it so important, especially for anesthetists? And from lessons learned since the SARS epidemic, I think that was way back in 2003, 2004, is that one of the riskiest procedures that we ever do in healthcare is aerosol generating procedures. And on top of that list is tracheal intubation. Now, as anesthetists, we know that's supposed to be our everyday bread and butter sort of activity. And so it's inevitable that as anesthetists, what we do on a daily basis doubles up as one of the riskiest procedures, especially during a pandemic like what we are going through in the name of COVID-19. Now, this study was published quite early on, probably 3-4 months ago. And essentially, it was looking at healthcare workers who undertook tracheal intubation and how many of them developed symptoms related to COVID-19. And the graph on the left essentially is looking at the kind of protective equipment that they were wearing. And as you can see from here, the vast majority of them were actually wearing appropriate PPEs. The biggest chunk of these practitioners were from Europe and North America, and they had PPEs at their disposal. But despite all that, up to 10% of them still developed symptoms related to COVID-19. They had to be quarantined. And essentially what then it means that out of that, despite taking all the necessary precautions, 1 out of 10 of the practitioners who are involved in the tracheal intubation actually contracted COVID. Now, whether or not that COVID was contracted during the aerosol generating procedures or they contracted it in the community, we can't tell from the study. But just as a pointer, at the same time, when 10% of this cadre of healthcare workers were contracting COVID, the prevalence in the community was about 0.1%. So it was actually 10 times lower in the community as opposed to this particular group of patients, meaning it's not possible that they all contracted it from the community or a good chunk of them contracted in the community. It must have something to do with the activities that they were involved in. And we know intubation varies, but the good thing about this cohort of colleagues is that the vast majority of them were consultants. So it was not that the trainees were struggling to intubate and exposing themselves. And also a good number of them, over 70% of them, 70 to 80% of them were actually anesthesiologists. So these are our colleagues who are very experienced in undertaking endotracheal intubation, but they were still contracting the infection despite wearing appropriate PPEs. Of course, then the question is, what could have gone wrong? Is it that the PPEs were worn badly? Was it at the time of donning? Was it at the time of doffing? Unfortunately, this study could not answer that question. And they looked at quite a number of them, over 1,700 in 500 hospitals across 17 countries. So it's quite a diverse population. The graph on the right looks at the symptoms that they most presented with, and I included it just to show that top on the list was not cough and difficulty in breathing, neither was it fever. The topmost symptom was actually fatigue. And we all know that COVID-19 presents with a variety of signs and symptoms. And I just put that slide there to show that it might not be the obvious symptom that we know about that will be the manifestation of our contracting the COVID-19. Now, I talked about the chain of infection, and this is probably the most important slide for this presentation, because once we understand how infection happens, then it's very easy for us to institute preventive measures and to try to control transmission of infection. Now, there are three key components of the chain of infection. One, of course, is the infectious agent itself, and that could be a bacteria, a fungi, parasites, prions, viruses, etc. And then you have the reservoirs, because these infectious agents have to stay somewhere, they reside somewhere, they reproduce there, and then you have a susceptible host. So most of the time, if we are talking about COVID-19, at least initially we thought the reservoir was some form of animal, whether it was bats or any other non-human animal. But as we speak now, when the pandemic is raging, actually the reservoirs are ourselves. So it's actually people. And that's where the COVID-19 virus is actually residing. Now, and then we have on the other end is the susceptible host. Again, when it comes to COVID-19, we are all susceptible, at least as far as I am aware. I don't think there is any category of human beings that seem to be resistant to the virus that causes COVID-19. So we are all susceptible. Some people might be more susceptible for severe illness than others, but in terms of actually contracting the disease, we are probably all susceptible. The difference is that some of the people who are infected are going to be asymptomatic, and so they are going to increase the pool of reservoir where the virus will reside without causing any disease. But the ones that are immune deficient, comorbidities, old age, and all that are going to likely develop more severe or critical COVID-19. Now, from the reservoir, for the virus to actually get to the susceptible host, there has to be a portal of exit. And that varies. Could be blood, secretions, excretions, could be just shed from the skin. Again, in terms of COVID-19, the commonest by far is the respiratory secretions. And that's how the virus actually exits the reservoirs. And the susceptible host has to have a portal of entry. Again, in the case of COVID-19, the portal of entry will most likely be the mucous membranes and the respiratory system. Of course, there are other potential ways of infection, but eventually it has to get through the mucous membrane, or if it's inhaled directly into the respiratory system. And in between those two levels, you have the modes of transmission, and that can either be by contact, droplets, or airborne. So as we all know, everything to do with chains, the chain will be as strong as its weakest link. And so our duty then when we are fighting infection control is look at areas where we can intervene and try to break that chain. So we could break the chain by protecting our susceptible hosts. In other words, you protect the portals of entry, and that's what we are trying to do when we talk about wearing masks, when we are wearing N95s and all that. We are actually trying to protect the portals of entry. And on the other hand, for the person who is infected, we are trying to protect the portal of exit so that the virus doesn't actually get out of the infected host and somehow get into the susceptible one. And then now during the modes of transmission, that's when now you have protective measures for contact transmission, for droplet transmission, and for airborne transmission. So all those interventions are actually geared at trying to break the chain of infection and so interrupt that transmission from the reservoir to a susceptible host. Now, hand hygiene, I'm sure we have seen this ad nauseum. It's everywhere, and it's highlighted even more during this pandemic, the 5 moments by WHO. And key among these, you have 2 that are before, and you have 3 moments that are after interacting the patient. So it's either before touching the patient, number 1, number 2 is before a procedure, and then you have the 3 that are either after a procedure, after touching a patient, or after touching the patient environment. And these are things that we are going to do every day as a part of our routine practice. Now, I'm going to interrupt the presentation and just look at something different. Please bear with me. I'm going to change the slide that we are sharing and then try to see if, so just bear with me. I'm going to share a different slide. And please get your smart devices out, because I'm going to request you to do a certain activity in a short while, just to get some idea of where we are at. So that's the question. I hope everybody can see the link at the top of the screen. So if you could just take less than 1 minute to just answer that question. So you go to www.menti.com and use the code that is projected there, the 4833705. If you could do that just around now, 1 minute, and then we move on. Can everybody see? I hope. Dr. Githaiga, can you see the screen clearly?
Yes, I can see the screen clearly.
Okay, lovely. All right, so please just take a minute, go to that site and try and answer. There we go. So 1, 2, carry on. Okay. We'll give it another 30 seconds or so. Okay. All right, so it looks like 0 to 5 times in the course of one anesthetic is the consensus. Any more? Going. All right, so 0 to 5, 5 to 10. Okay, so far 3 colleagues have said more than 10 times. Anybody else? Okay, lovely. Okay, now, can we all see my slide? Yes, Dr. Githaiga, you probably will be my reference point.
We're still on the Mentimeter slide.
You are still on the Mentimeter slide. Okay, so I think I'm going to stop sharing that slide. So we have an idea of the vast majority seems to say between 0 and 5 times in the course of one anesthetic. So I'll move back to my presentation and continue in the interest of time. So I'm going to share a very interesting slide. And people have actually looked at hand hygiene. And this is a very interesting study that was probably done 5-6 years ago. And they were looking at how the anesthesia work team, anesthesia colleagues, utilize hand hygiene moments. So in this study, essentially, it was an observational study. And we are just looking at how the anesthetic, from the time the patient is wheeled into theater to the time that the patient actually is wheeled out of theater. And the findings were very interesting. So within one anesthetic, they observed up to 24 opportunities for hand hygiene. And out of those 24, most anesthetists only sanitize their hands twice. So essentially, only 10% of the opportunities were utilized. Now, this study had multiple levels. So it was the baseline was 24 times. Of course, the 4,600 is composite for all the procedures together, but even then it was about 10% in terms of utilizing opportunities for hand hygiene. Of course, there were interventions subsequently, and what happened is they somehow managed to reduce the opportunities to 14 and increase the activities. By the activities here, we mean hand hygiene, hand rub, alcohol hand rubs, to 8. So it was a significant increase over several months, but essentially what they did is they realized that some of the things that we do as an anesthetist is we keep recontaminating ourselves. So we go, for example, touch the patient, you sanitize your hands, then you quickly forget and come back to the patient before moving on to something else. So essentially what they were doing is to reorganize the workflow so that you reduce as many chances of recontamination as possible. And that's how they were able to reduce the opportunities from 24 to 14 per anesthetic. And still, even after doing that and significantly increasing hand hygiene activities, the best they could get is 8 out of 14. So this is something that we don't think about, and I am certainly one of the culprits. I don't think I sanitize my hands more than 5 times in the course of one anesthetic, but it's something that we don't think about a lot. And now, this was just in terms of interacting with the patient. But remember, in the theaters, you're interacting with other inanimate objects. You are touching the surfaces, the anesthesia machine, the drug trolley, you are touching the computer if you have a computer in the room, you are tying up people who are scrubbing up, and all those are hand hygiene moments because you're interacting with the environment. But in reality, we don't really take advantage of that. Now, I thought that study was a bit off, but then again, when I looked further, I found another study which was not very different from the first one. The only difference is this study, they were looking at hand hygiene moments between induction of anesthesia and when the surgery is ready to commence, and for maintenance once the surgery has commenced. And again, this was for every 5 minutes. And you can see in every 5 minutes, especially at the beginning, you have up to 18 to 20 hand hygiene moments. Of course, it's not practical to sanitize your hands 20 times between wheeling the patient into theater and inducing and settling the patient to make them ready for surgery. But what these studies are essentially showing is that there are a lot more times when we are giving an anesthetic that we contaminate our hands than we might think about. Of course, gloves come in handy. And so we might say, well, but we wear gloves and this, and so that reduces the risk of contamination. But most of the time we wear one pair of gloves and you have to keep touching things here and there. So you actually cross-contaminate some of the surfaces. Of course, the advice is, especially for intubation, you can double glove, and then if the outer glove is contaminated, you can remove and discard and remain with cleaner gloves. But even that as a backup, studies have shown that we don't use them so much. Now, this is an interesting study that was done in Ireland. And as you can see, the consultants are the biggest culprits. So in terms of, wearing gloves, essentially, for certain procedures in theater, IV cannulation, intubation, extubation, and even removing a laryngeal mask airway, the consultants did poorly. Literally, only 10% of consultants were wearing gloves for IV cannulation, for intubation, and for extubation. The nurses did slightly better. These are nurse anesthetists, and of course the trainees did the best. But even the trainees, barely 60% of them were putting on gloves. Again, this was an observational study, and you'd imagine that because it's an observational study and people know that someone is watching, the Hawthorne effect will set in. But despite that, the findings were quite damning in the sense that even wearing gloves was not a very common occurrence. Now, we talked about modes of transmission of infections, and essentially you have 3 common ones, 3 main ones. We have the contact transmission, droplets, and airborne. And then the contact can be direct or indirect. So you are either directly getting the infection from another person, in this case, the reservoir, which might be the patient, it might be a colleague, it will be a member of the public out there in the community. Any of those could be direct contact. Indirect contact will be touching the knobs of doors, anesthesia working surfaces, and all the other inanimate objects where some of those virulent microorganisms have actually been deposited. Then, of course, we have droplets. And droplets are important, especially for respiratory viruses, COVID being one of them. And essentially, these are slightly bigger than 5 microns, and so they don't extend very far, but then they are shared through the respiratory secretions, either through talking, coughing, sneezing, or touching mucous membranes, and you are infected, and touching and so dispersing of the droplets into the environment. The droplets, by virtue of their size, don't go very far. And actually, the farthest that has been documented for droplets is up to 1 meter, hence the 1 meter distance of social distancing. The reason why we've gone to 1.5 to 2 meters distancing is just to create a buffer, so that if you keep it at 1 meter, then you are keeping it too close, because the farthest documented distance traveled by droplets is about 1 meter. Hence, we say, okay, fine, just to be on the safer side, then keep a distance of 2 meters, at least 1.5 to 2 meters. Now, again, that is easier said than done. We may be able to do that when we are interacting with patients in the wards or somewhere else, but for anesthetists in theater, keeping that distance is going to be quite a task, and literally impossible if you are going to actually take care of this patient. And then, of course, we have the airborne route, and that's where now the particles are aerosolized into smaller bits, less than 5 microns, and they can remain suspended in the air for quite a long time, and they can be inhaled. And so, of course, when these particles are inhaled, because of the size, the sheer size, they can actually travel much lower down the respiratory tract, all the way to the alveoli. And this is what we worry about when we are talking about aerosolizing procedures, because then what we are doing is we are aerosolizing some of those infectious particles, and they will remain suspended in the air in the theater environment or the ward environment or the ICU environment for quite a long time. And that requires a different form of protection. Now, speaking of COVID-19, as I've mentioned, those are the 3 main routes of transmission. And essentially, depending on where you are, contact transmission, you have to come into direct contact either with the patient, with an infected person, or contaminated surfaces. And contaminated surfaces in theater could be anywhere. There's a study that looked at potential contaminated bits in theater, and they were looking at over 1,000 different ways in which you can come in contact with infectious material. So it's quite a bit. And then, of course, we talked about droplets, and then there is the airborne when we perform the aerosolizing procedures. Because of those 3 forms of transmission, and these are specific transmission-based precautions, then you have to think about what is the best way of preventing infection. And this especially is from an infected patient to a healthcare worker. In this case, because we are talking about anesthetists, so we're talking about, as an anesthetist, what do you need to do when you are faced with a patient who is likely to be infectious? Of course, if you're worried about contact precautions, contact transmission, then the best approach is to keep your distance. Now, we all know, like I said before, that might not be possible if you are the one giving the anesthetic to that patient. But what then it means is that if you really are not involved directly in that patient's care, then probably you need to keep your distance. And the distance here is at least 2 meters away. If you have to work within that environment, even though you are keeping a distance of 2 meters, then you need an apron and gloves just to protect from contact infection. So you're talking about if you are going to deal with surfaces that are potentially infected, even if the patient is not in that room, then you need your gloves, because then you are at risk of contact transmission of infection from contaminated surfaces to yourself. Then, of course, if you're talking about droplets, then they become important if you can't keep the 2-meter distance. So if you can't keep the 2-meter distance, then you're at risk of droplet infection, because these droplets can then get in contact with mucous membranes, and that will act as a portal of entry. So in that case, you need to add an additional layer of protection. So in addition to the apron and gloves, then now you need to wear a fluid-resistant surgical mask. So it's just a surgical mask, because then the droplets are quite big. If you are wearing the surgical mask appropriately, then it's unlikely that the droplets will get in touch with your mucous membranes. Of course, then you need to also, depending on what kind of activity you are doing and how risky it is, you may want to consider eye protection as well. Because if you are very close to the patient, then droplet infection becomes real, because then the distance that the droplets have to travel is a lot shorter. Then, of course, the ones that we worry about the most, that's the aerosol generating procedures. And in that case, if you are in an environment where aerosol generating procedures are taking place, or you are the one performing that aerosol generating procedure, then you need airborne precautions. And now airborne precautions, you add an extra layer to the first two precautions. So in addition to gloves and aprons, you need a fluid repellent long-sleeved gown. You will need eye protection, mandatory, and you will need an N95 or equivalent respirator. And that will be able to now protect you appropriately from airborne infections. Now, what you need to understand about these layers is that the subsequent layers protect you from the previous risk. So if you are wearing, if you are taking droplet precautions, then that will protect you from contact precautions as well. So if you are wearing airborne precautions, that should be able to protect you from both contact droplets and airborne transmission of the infectious disease. Now, when we are talking about eye protection, please remember spectacles do not count as eye protection. So even if you are wearing glasses, if you normally wear glasses, you will need an extra layer, either goggles or a visa, to try and protect your eyes. Now, for anesthetists, aerosol generating procedures are a big deal. And because this is already documented as one of the high-risk procedures, especially for healthcare workers. These lessons were learned from SARS-CoV-1, the SARS epidemic that happened over 10 years ago, that the vast majority of healthcare workers that were infected by SARS got it through aerosol generating procedures. So essentially they were inhaling them. Now, as an anesthetist, most of these things are procedures that we are likely to do either in theater or in the intensive care unit, be it tracheal intubation or extubation, manual ventilation, bag mask ventilation, tracheostomies, bronchoscopies, and a whole lot of procedures, non-invasive ventilation, CPAP, high flow nasal oxygen. All those are potential aerosol generating procedures. So it's nice to have an idea of what those procedures are, and you take appropriate precautions. For us, if we are in theater, chances are if we are giving a general anesthetic, we are likely to undertake at least 1 or 2 aerosol generating procedures, even if we are not intubating that patient. This is just a slide to show some of the PPEs. Now, the picture here is full PPE for aerosol generating procedures. And like we said, this will protect you against contact transmission and droplet transmission, in addition to airborne transmission from aerosols that are generated when you are doing aerosol generating procedures. So all the way from head to toe, the cap, the goggles, the gloves, the apron, and the water repellent gown, and even the boots. On the right, I've put pictures of some of the top one is the N95 mask. This is an FFP3 at the bottom. They are supposed to be equivalent. Now, the reason I have put this here is just to demonstrate that some of them come with expiratory valves. So this has an expiratory valve, and the lower one too has an expiratory valve. The expiratory valves are quite good because they make expiration slightly easier for the person wearing it. The problem is the protection is one way. So wearing an N95 mask with an expiratory valve will protect you as the healthcare worker from infection, but it does not protect the patient or your colleagues if you are asymptomatic with COVID-19, for example. So it protects you, it does not protect everybody else who is around you, including the patients. So we wear it to protect ourselves, but in the event that we are the ones who are the reservoir and are asymptomatic, then we risk transferring that infection to our patients or to our colleagues. So you can imagine doing a laryngoscopy and you are asymptomatic with COVID-19, you are wearing an N95 and you are directly breathing into the face of a patient in which you are doing laryngoscopy. So of course, then that patient is not protected at all. So because of that, there have been guidelines that suggest that in addition to wearing an N95 to protect yourself, then you should add a layer of a surgical mask over on top of the N95 to protect our colleagues and our patients in the event that we have COVID and we are asymptomatic, so we don't know. We are completely fine, but we are actually reservoirs. Now, the mask, the surgical mask, the water repellent surgical mask has to be worn on top of the respirator mask, not under it. The reason being that if we wear it under the N95 mask, then you are going to interfere with the seal. And so what will happen is that now neither you nor the patient nor your colleagues will be protected, because now you've interfered with the seal. So there's a lot of entrained air around the N95, which will not protect you. And when you breathe out, even though there's a mask on the inside, there's a lot of leakage around the N95. So if you have an N95 that has an expiratory valve, then it's advisable to wear a surgical mask on top. Once you have tested the N95 mask and it's fitting well and it's all set in, then you put a surgical mask on top, try and protect everybody else that is going to be in that room, including the patients that we are going to be intubating or performing aerosol generating procedures on. Okay, now I'm going to pause there again and share something else that I would like you to again take out your gadgets and we do a small exercise quickly. The same website is just, it's going to be a different code. So just go to the same website, menti.com, and use the code that now you are seeing in front of your screen, the 7482555, and just try and respond to that question as quickly as we can. Again, it's just quickly so that we can move on, maybe 30 seconds to 1 minute tops. There we go. So essentially we want to know after how long. So you've done an intubation in theater, you've asked your colleagues whether you want them to stay or you want them to leave. If you want them to stay, then of course they don't need to leave the room. If they're leaving the room, how long should they come back after you've done your aerosol generating procedure? Or is it even necessary for them to leave the room in the first place? Okay, so we have 5, 6 respondents, 7. Okay, there we go. Keep going. Maybe in another 30 seconds, we'll close the survey. There we go. Thank you very much. Anybody else? So we have about 16 respondents. Okay, so it clearly looks like after 15 minutes is carrying the day. Okay, thank you very much. So 15 respondents have said after 16, 17. So the vast majority are saying after 15 minutes. That's very good. Looks like we know what we are doing as anesthetists, which is a good thing. The reason I put that out is because of this aerosol clearance time. Now, generally, we recommend that if we are doing an aerosol generating procedure, because remember, we are all gowned up and wearing full PPEs to protect against airborne infections, but then not everyone might be wearing the full PPEs. So in that case, then it will not be safe, for example, for someone else to come into that room and their protection is only against contact and droplets, because then the aerosols are going to still be suspended in the air for quite some time. Now, if we remember the exponential curves, so there are very many air exchanges that happen, especially in theater, sometimes in ICU and the wards. And essentially, one air exchange will reduce the viral concentration in the air by 63%. And so you need around 5 air exchanges to be able to reduce that load to less than 1%. And that's where the Act 5, the aerosol clearance time 5, comes by. So you need 5 air exchanges to be able to reduce that the load of the virus in the air after an aerosol generating procedure to less than 1%. Now, of course, that will depend on what the air exchanges are per hour in where you are working. So these are just some of examples, but it would be fair if we talk to the biomed team, then they will be able to tell us exactly what the air exchanges are in our various institutions. So a well-ventilated ICU, for example, will have 12 air exchanges per hour. So you'll need 25 minutes. A well-ventilated OR will have around 25 air exchanges per hour. That will be around 12 minutes. Generally, the wards will have around 6 air exchanges per hour. So you'll need close to an hour for people to come back in. So it just gives you an idea of how long it takes. So definitely based on those statistics, it won't be a good idea to do aerosol generating procedures on the ward, because then the aerosols will be suspended in the air for quite a while. It's unlikely that you will clear the ward for 1 hour before anybody else can walk into it. ICU is a bit more restricted, especially if you are a negative pressure room, and then theaters with the positive pressures and frequent air exchanges, then you need less. So actually the group that was saying 15 minutes were closest, but the right answer is actually once you understand how many air exchanges happen in the area where you're doing the aerosol generating procedure, then you can work out how long it will take for you to have 5 air exchanges. And that will determine when it is safe for members of your team to come back. Now, quickly, I'm just going to run through the anesthesia journey for some of the patients. And this will strictly be for patients that we suspect either have COVID or are confirmed to have COVID. Those are moderate and high risk. The low risk ones are the ones who are negative. But as we know, a negative test does not necessarily mean that the patient doesn't have COVID, because we know about false negative tests as well. And in addition to the false negative tests, if you are going to do the test because we don't know, the turnaround time varies from one unit to another. In our setup, we say 24 to 48 hours, but does not necessarily mean that the patient has not turned positive from the last time the test was done. So it's quite confusing. So actually, it's safer when you get a positive test, because then you can take precautions. It's a lot riskier if you get a negative test. And in areas where they use the test to actually say this is a low risk, it's in addition to the negative test, it has to be that that patient was in self-isolation over the last 14 days. So if you have in isolation, if you've been in isolation for 14 days and you have a negative test, then at least we know you are unlikely to be infected. Any other scenario, you are either moderate or high risk. Now, there are certain challenges that then will come with that kind of scenario. So for example, if you are doing a preoperative assessment, do we social distance or do you wear full PPEs and say, well, this patient could potentially be infected, and therefore, for example, they might cough or sneeze and generate aerosol. So even if I keep my 2-meter distance, contact and droplet might not be enough precaution. Do I need full PPEs? Again, that is something that we need to risk assess our different patients. but we've also learned that sometimes patients are a bit mean with the truth. So even if you inquire from a questionnaire, you might not get the right information. So it becomes quite a challenge. It's even more challenging, for example, even if you say this patient is low risk relatively, and so you're asking the patient to wear their surgical mask, you are wearing your surgical mask, you keep your distance, your 2-meter distance during your preoperative assessment. How do you assess the airway? So we may have sometimes to forego the Malampati score and adequate assessment of the airway, or you will ask the patient to remove the mask and open their mouth, but from 2 meters away. And you're hoping that they are not going to cough or sneeze, because if they do and you only have a surgical mask, then you are not adequately protected. So your assessment might not be adequate, which becomes challenging, because then you are relying on that airway assessment to determine how difficult it will be. For example, if you want to intubate this patient intraop, how difficult will it be to face mask ventilate this patient? Because the tighter the fit for the face mask, the less the risk of aerosol generation. So these are challenges that you have to face. And so if you don't have the appropriate PPEs, they haven't been provided by your institution, then the best way would be to wear a surgical mask and keep your 2-meter distance and try to assess this patient from 2 meters away, which is quite a challenge. And so, in other words, our preoperative assessment might not be up to speed. You might forego auscultating these patients, especially if there's nothing to suggest that they have cardiorespiratory compromise. Your airway assessment might not be adequate. And these are things that will complicate your intraoperative management of this patient. Now, when it comes to intraoperative management and you treating this patient as either confirmed or suspected COVID, then there are certain things that we can do to try and minimize the risk to ourselves, as well as the risk to our colleagues who are in that theater as well. So one of the things we have to think about, remember we said aerosol generating procedures are the biggest risk, especially for healthcare workers. And that happens quite a lot, either in the critical care unit or in the operating room. So the first thing you have to consider is, must I do a general anesthetic for this patient? Because most of the time, the aerosol generating procedures will show up when you are doing a general anesthetic. If you can get away with a regional anesthetic, then you only need to worry about droplet infection and contact transmission, and not aerosol generation. But then again, if you are doing a regional technique, then from the word go, you need to have determined what are the chances that the regional anesthetic is going to fail, and you have to convert this patient to a general anesthetic. Again, that will play a big role in trying to determine whether you should just go full PPE, even if you are going to do a regional anesthetic, because you are saying, well, it could fail, and I won't have the time to actually go outside, remove what I had put, and now wear the full PPE to be able to deal with an aerosol generating procedure. So, but if you can, you avoid GA. Airway management becomes a challenge. Are we going to intubate the patient versus a supraglottic airway device? Most of the time, if it's high risk, then we have to do rapid sequence intubation, because we need to avoid bagging the patient, because that in itself can be aerosol generating, meaning we have to pre-oxygenate the patient. And even the pre-oxygenation, we have to use low flows so that we minimize the amount of leak. So we are talking about less than 5 liters per minute using the anesthetic circuit. And even the anesthetic circuit will probably want to use the closed circuit from the word go, rather than going with the Mapleson A, for example, until the patient is asleep and then switching to the closed circuit, because then there will be a lot of leakage and you run the risk of aerosol generation. From induction to intubation, ideally, if possible, you will be able to avoid ventilating the patient with the face mask. If you can't avoid it and the patient is desaturating, then preferably you need an able assistant who will be able to help you, and you do forehand ventilation, where you are holding the mask with both hands and an assistant is ventilating the patient using low flows and low pressures. All this is geared to try and minimize aerosol generation. And even once you intubate the patient, certain things might be done differently. For example, you might not auscultate to confirm correct placement. Instead, you might have to just use your direct visualization to confirm symmetrical chest expansion. And then if you have the capnograph to confirm that you are actually in the right place. And then you look at the depth of the ET tube vis-a-vis the size of the ET tube that you actually used. Most of these theaters, if you have a suspected case, then you need an anteroom, a room that is adjacent to the actual theater. And this comes in handy because then you don't contaminate some of the equipment that you may or may not use. And also you have staff, for example, the scrub nurse, preparing all the equipment in a separate room while you are inducing the patient in the actual OR to try and save on time. Because remember, while you are doing aerosol generating procedures, ideally the rest of the team need to be outside that room. And they only come in after 5 air exchanges, ideally. If they have to come in before then they must wear full PPEs and come in with full protection against airborne transmission. And we know, depending on the institutions that we work in, some institutions might not have adequate supply of PPEs. So in that case, if you cannot protect yourself against airborne transmission, then you have to wait for that time to elapse so that you're hoping that most of the aerosols have actually settled and now you are back to just contact transmission and droplet transmission. And that's what you have to worry about. In terms of post-op care, again, most of these patients will be recovered in theater inside the actual operating room because the theater is already contaminated anyway. Now, remember, just like we said, intubation is aerosol generating, so is extubation. So again, you need to clear the theater from non-essential staff, and you probably remain with an assistant to reverse this patient, extubate them. Depending on the fasting status and the difficulty of the airway, the ideal would be to extubate the patient deep so that you minimize coughing. But if you have to do an awake extubation for patient safety, then maybe if you have something that is going to reduce the risk of coughing, whether you're going to use remifentanil or local anesthetic to try and minimize the risk of coughing, then it's advisable to do so. And then once, of course, you've extubated the patient, then you will just move directly from the theater to wherever pre-op area that patient came from. If this is a theater that you are going to use for non-COVID patients as well, then there has to be enough time between the patients so that you can actually clean the theater properly. Terminal cleaning, sometimes you may use UV light. We have seen UV light is useful. It clears the virus from some of the air, especially the upper layers of the air in circulation in the theater, but you need quite some time, up to 2 hours, actually adequately clear the room. And then, of course, all the surfaces have to be cleaned adequately because, again, you are trying to prevent the 3 modes, the 3 main modes: contact transmission by wiping the surfaces of places where the droplets would have easily settled. And then you're also trying to clear the aerosols that might have been suspended in the air while you are doing the aerosol generating procedure. Now, obstetrics is a lot more interesting and challenging because, in addition to everything else, we all know that when it comes to labor, there is no timing. It comes at any time. And so, how do we deal with obstetric patients? If you are in a center that has epidural analgesia services, then that would be a good option for all the patients who come and they are COVID positive and they are in labor, because a neuraxial block are not contraindicated. And what that will do is that it buys you time so that in the event of an unplanned cesarean delivery, then you can easily top up the epidural and try to avoid general anesthetic. Remember, the more you can avoid aerosol generating procedures, the safer it is for you as an anesthetist and also our colleagues in that theater, especially if you are dealing with a patient who is confirmed or suspected to have COVID. The only thing we need to remember is that sometimes these patients have documented thrombocytopenia. So you might want to check your platelet levels before doing the regional technique, be it the epidural or the spinal anesthesia. If it's for cesarean delivery, spinal anesthesia or epidural, if possible. But we all know that there are some levels of cesarean section, category 1, for example, where an epidural might not be the best option, and so you have to give a general anesthetic. But the indications are not going to change. The only thing that we have to remember, and this we learned when we were trying to do dry run simulations, is that it takes quite some time to dawn. So, and remember, this is an unplanned delivery. So it's a category 1, for example, you had not planned for it, and your safety comes first. So this is something that we have to remember, that we have to take care of ourselves and our colleagues first. By extension, then it will mean that the decision to delivery time might not be what is expected. So for example, if you are saying that for a category 1, decision to delivery time should be between 15 and 30 minutes, you might not achieve that, because remember, all the staff have to dawn. And the category 1, if you are going to do an aerosol generating procedure, you might not have time for staff to stay outside and wait for aerosols to settle down before they come into the room. So everybody will have to wear full PPEs to protect against aerosol, airborne infection. That will take time. So the families, the patients, and everybody else need to understand that this is what is going to happen, so that then it doesn't become an issue later that it took so long from the time the decision was made for a cesarean section to the time that cesarean section was actually done. And that's why it's important for those patients who come in labor and they are known or they are high risk of COVID and they agree to an epidural, that would be a better option, because then all you need to do is top up the epidural. Now, things to remember when we're doing a general anesthesia for cesarean section is some of those PPEs make communication quite difficult. So you might need to work with a team that is used to this, and simulation will come in handy in that case to try and just know so that everybody is on the same page and you work seamlessly. It's going to be an RSI, of course. If you're giving a general anesthetic, you will need a tight seal when you are pre-oxygenating with low flows. And although high flow nasal oxygenation can be used, it's one of the potential aerosol generating procedures. Intubation, again, like we said, is going to be an RSI. If you have a video laryngoscope and you know how to use it, then that is advisable, because then what it does is it allows you to stand a distance from the patient's face while you are doing the intubation, and that can minimize the dose of aerosol that you will be exposed to. If you run into difficulty with intubation, you might have to change your plan a bit so that you are not going to revert to face mask ventilation and you go to front of neck access, but that's only if you are competent and comfortable with doing one. Of course, what you need to remember, you put that glove because you are going to touch secretions. And remember, I mentioned about confirming the correct ET tube placement. Extubation is equally high risk, so you are going to take the same precautions. Now, a little mention of the anesthetic machine, because there is always the risk of contaminating the machine and infecting the next patient. So what happens is then, instead of the standard 1 HME filter, it's recommended that we add a second filter on the expiratory limb to protect the anesthetic machine. So you have your HME filter on the patient end at the end of the eyepiece, and you have a HEPA filter on the expiratory limb to protect the machine. Your gas sampling, if you have capnography, should be on the anesthetic machine end of the HME filter. Now, these HME filters, again, if you have one, you need to be sure that it have viral filtration capabilities, because not all of them are filters. Some are plain HMEs without viral filtration. So if it's a plain HME, then you probably are not going to actually protect this circuit. So it has to be an HME that has a viral filter inbuilt that is going then to protect the machine end of the circuit from the patient. And we're talking about patient with suspected or confirmed COVID, or one whose status we don't know. Now, there might be a few changes in pediatrics because of the dead space. The changes will not involve the HEPA filter on the expiratory limb that is protecting the anesthetic machine. The changes might be in the HME filter because of dead space, some of the pediatric filters don't have viral filtration capabilities, which means that there's potential for the viral particles to be sampled when you are sampling for capnography, and through the gas module, contaminate the machine. So one of the suggestions to overcome that has been that you use a drug filter, like for example, the one we use for the epidural catheters, and you put it on the gas sampling port, and then you connect the capnography sampling line for the side stream capnograph. And that possibly will help you with protecting the machine. And then, of course, the anesthetic assistants have to actually clean the surfaces of the machine, especially surfaces that you are likely to touch, the knobs, the screen, everywhere that you're likely to touch, so that by the time the subsequent user comes in, they don't run into a risk of contact transmission. Of course, this is all complex and this is all new. So how then do we become efficient at it? The best we can do is simulate. And some of these scenarios, you might not meet them every day. So you have to have drills so that you maintain the skills, we maintain the knowledge, we know the systems and our SOPs, which are institution specific. We were lucky to have Dr. Wangui Thanga at our facility, and she developed brilliant simulations for COVID-19 scenarios. They were hard to make, and it was a lot of work. But after we all went through it, we appreciated just how difficult it's going to be to manage some of these patients. And even after going through the drill over and over, when the real patient shows up, it's quite a task to prepare, because we are running scenarios of how you move this patient from one end of the hospital to the other without contaminating the corridors, without contaminating the lifts, without contaminating the doorknobs, avoiding PACU, avoiding pre-op area, and it was quite a challenge. But at least if you run those drills over and over, and I think Christian will mention this because he has been actively involved in simulations and creating some of those drills and training staff on what to do. He can talk to us more about that, but it will just help you prepare and be ready when that scenario shows up. I promise I'm about to finish. So I'm going to request you one last time just to fill in again one of my questionnaires. Let me see which one that is. Please get your hands devices ready again. I hope the network allows me, and we'll just do one more and we'll be done. Okay, so that is the next question. This is just about us when we are working and how we feel. So if you could just quickly, again, the code is at the top of the screen, 1943033, same website, menti.com, as we wind down. There we go. One person has responded to. Okay, 3. Okay, a few more seconds. So sometimes and all the time. Okay, sometimes, most of the time. Okay, lovely. Keep going, keep going. Okay, so we have 17, 18 responses. Okay, so only one person has said never. So the rest of us, at least sometime, all the time, most of the time, we feel a little bit disconnected. That's fine. I will go to the next question. And that is the question. So again, the same. Do you regularly feel emotional exhaustion, like you have nothing left to give, as in the system has drained everything out of us? Yeah, and really there is nothing else left. There we go. Most of the time, sometimes. Okay, a few more responses, then we move on. Okay, so far, most of the time and sometimes. Okay, 8 respondents, 9, 11. Okay, never. I would like to work in that institution where that feeling never shows up. I think that's very good. It means you have quite a decent support system. So 16 respondents, 17. Okay, lovely. Okay, now the reason why I brought that up is because one of the things that we don't know what to do is to take care of ourselves as doctors generally, and I think anesthetists even some more. But we need to take care of ourselves. So there are resources online that you can use. There are posters that have been shared, especially from the UK, that you can put in various areas and just essentially find out if we are okay. And it's also okay not to be okay. So we are not supermen and women. Sometimes we burn out as well. So, and I think for us to be able to take care of ourselves, we have to take care of our well-being, because all these things we are talking about, infection control and the precautions we have to take, are going to be meaningless if you are exhausted, because then there will be breaks in the concentration, and that will mean increased risk of either infecting ourselves or infecting our colleagues in our work areas. I'm going to stop there. Thank you very much. My apologies for rushing through the presentation. Thank you.
Thank you, Dr. Odaba, for that timely and appropriate talk on how to navigate the new normal in preventing perioperative infections. You've touched on salient points, especially on how to break the chains of infection, both in standard precautions and transmission-based precautions. And we've learned quite a bit, and you've also reminded us of the steps that are very important, especially in the times that we live in. I'd like to remind all of you to target your questions to the chat, and we'll look at them at the end of the webinar. We can also answer as we go along. Keep your mics muted and your cameras off. We're going to move on to our second speaker or panelist, and I'd like to introduce Dr. Christian Kampik, who holds an MSHB from Nelson Mandela Medical School, South Africa. He also holds a diploma of anesthetics and fellowship of anesthetics, and is currently principal specialist lecturer and head of pediatric anesthesia unit at the University of KwaZulu-Natal. His interests include pre and postgraduate student specialist training with special focus on simulation and research. Other areas of interest include pediatric and neonatal anesthesia, regional anesthesia, management of the difficult airway, and he's also very active in rural health outreach programs to serve and uplift underprivileged communities. Welcome, Dr. Kampik.
Thank you so much, Dr. Gitaga. Thank you for having me. Okay, I'd like to thank, first of all, Dr. Odaba for this very interesting and informative and thought-provoking talk. I think we're all struggling with infection control during this pandemic. I thought that I'll talk a little bit about punitive measures that can be taken from your institutions if people and staff are not adhering to infection control measures, and this is a big problem because basically there are no punitive measures that can really be instituted. So what we have done, we've tried initially to increase awareness about the transmission of COVID, and we've done protocols and policies, and try to educate staff. This was very difficult initially, and it was as the pandemic started and the patient numbers started to increase slowly, we could not really achieve compliance. And this was with basic infection and prevention control measures like social distancing, mask wearing, and hand hygiene. So basically what happened then was that the coronavirus actually took over in handling the non-compliance, and we had a big surge in infections amongst all cadres of healthcare workers and professionals at our hospital. So we had about for about 5 to 7 weeks, we had in between 5 to 35 new infections amongst healthcare workers daily at our institution. And the interesting thing was that these infections were not done from patient to the healthcare workers, but the spread occurred amongst the healthcare workers themselves. So the worst affected here were unfortunately the nursing staff. And the most common areas that we found of being transmitted, of having transmissions, were actually the tea rooms and the lunch rooms. So it was infection from staff to staff that eventually resulted in more than 600 of our staff at the hospital being COVID positive, which is about 20 to 25% of all of our staff. So another interesting aspect here was that the number of infections of staff in the COVID ICUs and wards where we were treating the actually positive patients was actually the lowest. So it was it took quite a long time before staff started adhering to IPC policies, and the numbers decreased. So then we had quite an increase of patients, and we had to deal with our first wave, which is now settled, and we're hoping that the second wave is not hitting us in South Africa, where we're having about 70% of the COVID positive patients and death of the whole of Africa. So unfortunately now at the moment, what we're seeing is that COVID fatigue and the mask fatigue, as I call it, is setting in. As the numbers at the moment are decreasing and the lockdown measures in the countries have been eased. So people think it's kind of over, but unfortunately it doesn't seem to be like that. As we can see in Europe, which is heavily hit by a second wave, and even in South Africa, the numbers in parts of the country, in some provinces, are steadily increasing again. And we have some hospitals in the Eastern Cape province, for example, government hospitals that are starting to overflow. So it's a big problem. And the other problem that we're facing at the moment is that initially during the pandemic, we had to cancel all elective surgery, which obviously creates big issues for the general population. And since the numbers have decreased again, we had to start elective surgery or non-COVID surgery or surgery for COVID negative patients. So this creates a big problem. We've got a COVID theater that has been set up. But how do we go about treating patients that are COVID negative or coming for COVID negative surgery? Dr. David took us through how to treat COVID positive patients intraoperatively, but what do we actually do with patients that we are hoping that are negative? So we are lucky in our facility that we can test all our patients preoperatively before elective surgery. Obviously, we have a turnaround time since our hospital, our institution is testing for the whole province, our lab. So we've got a turnaround time of about 24 hours at the moment, which is quite good. So we get our test results fairly quickly. Other government hospitals have to rely on screening alone. So we screen patients and decide from there if we deem them positive or negative. And as we've it's been alluded to earlier, a negative COVID test does not necessarily mean that the patient is in fact COVID negative. So we do get caught out every now and then, still at the moment. And the biggest problem is the emergency procedures, because we test the patients that are getting admitted for emergency surgery, but we don't know the result. So we have to treat them as potentially positive patients. Now, how do we go about this? Because we don't have enough PPE and we don't have enough COVID theaters to treat every patient where we don't have a result as a patient under investigation, a POI or COVID positive patients in a COVID theater. So the policy for us is at the moment that we screen the patients that come for emergency surgery. We test them, but we can't wait for the result. So if they screen negative, we are meant to admit them in the normal wards, and we are meant to treat them in COVID negative theaters. Now this is an area where we are getting caught out relatively frequently, that we have patients, many trauma patients, that screen negative. They've got no COVID symptoms. They're asymptomatic. They have an accident. They need emergency surgery. We take them to the normal theaters, and the next day we get the results, and it comes back positive. So the number of COVID positive patients that are actually asymptomatic is relatively high, and that is worrying. So I think I would like to hear what other people, what other institutions do in other countries, how they deal with this problem. Another thing I just wanted to allude to quickly was the role of simulation. I think it's very important. We set up a COVID theater at our institution, and we created protocols. And initially with the anesthetic department, with anesthetists, we did intubation drills so that everybody is comfortable with doing aerosolizing procedures. The other drills that we did with simulation in the operating room is repeated drills with the whole team. So this includes the nurses, the surgeons, the anesthetists, everybody who's involved in the management of the patient. And we start preoperatively with a meeting, and we start with repeatedly the donning, and then fetching the patient from the COVID positive ward, getting the patient to theater, doing the intubation, getting everything in order, how it needs to be done, and then disposing of the patient post-operatively. I think it's very important to involve the whole team there and to do this repeatedly. Don't just practice it once, and then you might not have an actual COVID positive patient for maybe 2 or 3 weeks, and then a patient comes, and then you've forgotten everything. So it's important we try and do every 2 to 3 weeks to have a trial run, because at the moment we're not having a lot of COVID positive patients. So I think that is very important. We've just finished a live simulation video from our department. I'm happy to put the link from our university website, from our department's website, onto the group chat. How we are treating COVID positive patients in terms of infection control. It fits perfectly into this topic here. Happy to put that on the group chat. And yeah, so that's all I've got to say at the moment. I'm happy to take some questions, and thank you.
Thank you, Dr. Christian. Thank you for that presentation. You reiterated the importance of perioperative testing for COVID-19 and also the importance of stimulation when it comes to dealing with COVID positive patients. You don't want your first time to be on an actual patient. So practice makes perfect, and we have to continue to practice as we go along. Last but not least, I'd like to introduce our final speaker of the evening. The next speaker is Dr. Adetoye, who is a lecturer and consultant anesthesiologist with Obafemi Awolowo University Teaching Hospitals in Nigeria. He has a basic medical education at Ile-Ife University, Nigeria, a fellow of West African College of Surgeons, and has a certification in basic and advanced interventional pain therapy from the International Pain and Spine Center, New Delhi, India. His passion for patients' comfort influenced his career choice in anesthesiology, intensive care, and pain therapy. He has also been part of renal transplant, open heart surgery, fistula surgical teams, and presently is a member of the COVID-19 response team. He's a member of the Nigerian Society of Anesthetists, Society for the Study of Pain, International Society for the Study of Pain, and he also pastors a church in his free time. Welcome, Dr. Adetoye.
Okay, that's good. If it is clear now that I can go on. The question for me, since I've lost some time, is most infection control and prevention champions tend to be nurses in most hospitals. Is this the case in your institution as well? If not, how did you get by? As surgeons and anesthesiologists. Well, the infection control champions in our hospital, all around the hospital, though the hospital has an infection control committee headed by a physician who is a microbiologist, a consultant microbiologist, and but because the microbiologists are fewer, and also the hygienists join them in this team. So the nurses are, could be said to be the champions all around the hospital because you meet them virtually on every ward, especially when we talk about the theater environment, the perioperative nurses, because they are the ones on ground most of the time. They tend to be the ones in charge and tend to guide others and check others as well when they are about falling out of the ideal. They oversee most aspects of the procedures in theater, like the scrubbing process, taking care of instruments. From time to time, the perioperative nurses are the ones who take culture samples, swab samples for culture and sensitivity to be sure that the theater environment is still sterile as much as possible. And whenever a non-sterile procedure, maybe a laparotomy for ruptured appendix, and the dirty cases are taken in the theater, they are the ones who will inform the hygienists, the environmentalists, to come and fumigate that particular theater, close it up for some time, clean, and fumigate. And after the due time, it will be reopened again. Let's come to the era of COVID-19. The COVID-19 pandemic had actually changed events in our hospital significantly. In fact, there are some other health workers who were hitherto not that keen about taking necessary precautions are now doing so, because at a point we even had significant infection. Almost about 75% of the workers in the theaters were infected with COVID-19, though about 85% of them didn't come down with symptoms. But when the tests were carried out, they were positive. So as soon as everyone overcame that episode, people became more careful. And in fact, that in itself has increased the cost of surgery and surgical interventions in our hospital, and even some other interventions all around, because most of our patients do out-of-pocket payment. So they now have to buy N95 masks, the aprons for the cadre of workers, though now we limit the number of workers that will go in to attend to each patient. But there's an increment in what is requested of the patient to provide, so as to protect the health workers against infection by the patient, and also protect the patient the other way around. Because when the health worker is trying to protect himself, then he will invariably be protecting the patient as well. Aside the fact that, as the earlier speaker said, that when you wear the N95 mask with respirator, you are protecting yourself, but whatever comes out of you can still get through to the patient. But significantly, the nurses have played a significant role because they are the ones guiding all these processes, ensuring that these materials are provided, ensuring that they are properly used so as to protect the theater environment, protect the patient, as well as protect the health workers, so as not to have another wave of infection. This has been their major, but that team that I spoke about earlier on the committee still sees a lot to the fact that such practices are reviewed from time to time. There was a time during the pandemic that we actually had to be doing some screening tests just to reassure the workers after the wave of infections and people resumed again, that they had to be doing some screening tests for the patient. Though it is said that screening tests, except the screening test is of no value significantly. So we all resolved rather to donning appropriate PPE for the level of risk that we think is associated with the patient we are attending to. That way, we're able to prevent infection transmission from patients to health workers and from health workers as well to patients. So in that wise, significantly, I would still agree that the nurses are the champions of infection control and prevention on most of our wards and even in the theater environment, though guided by the physician microbiologist. And that's what we do in our hospital. And this has saved us a lot. And we're able to practice relatively freely now. And we can attend to more patients by at least assessing the patient, assessing the risk involved, and donning the appropriate PPEs, which the nurses actually ensure that everyone does properly. And the traffic is also reduced. So by this, we're able to achieve a lot, attend to more patients, protect ourselves, and then work is going on. So I will say, in summary, that for the surgeon and the anesthetist, more people are now practicing the ideal, that is the standard precautions, the precautionary measures, so as to prevent being infected by the COVID-19 and some other infections. In fact, in Nigeria presently, there's a wave of yellow fever infection going on, in addition to Lassa and the likes that have been on ground even before the COVID-19 infection. So everybody is becoming more careful. Hand washing, hand scrubs, and the likes are being applied. And so the ideal is being done. But the nurses are still the ones who are the watchdogs, quote and unquote, ensuring that these things are done and that the environment is safe for all to practice, for patients' protection and for the health workers' protection. Let me stop there. If there are some other issues raised during the course of the question and answer, I'll be able to contribute more. Thanks for the opportunity. And I'm done.
Thank you, Dr. Adetoye. Thank you for reminding us that nurses are the champions of infection control and the importance of wearing appropriate PPE in the correct manner as well. So we've run out of time. I'd like to take one question directed to Dr. Odaba. And Dr. Celestine would like to know if a patient with COVID-19 can complicate into acute respiratory distress syndrome, dry cough, without having a fever. We'll take one question and then move on to our sponsors. Dr. Odaba.
Thank you, Dr. Gidaiga. Yes, it is possible. And I think COVID-19 is a disease that, as much as we try, we still don't know a lot about. And in fact, most of the time, I wonder when you go to areas where they take your temperature and assume that's probably the only thing that will tell whether or not you have COVID-19. Because if you remember the slide that I shared about the study that was looking at aerosol post-intubation infections, fever was not even among the top 5 symptoms for that cohort. It was an observational study, yes. It was self-reporting, but still fever was not a big problem. And just like any other disease, I guess the adage still stands that, well, diseases don't read textbooks. So you can have a patient who presents with all the organ dysfunctions and they don't have a fever. And it happens, like, because remember, even COVID-19, when the patients are presenting with the multi-organ dysfunction, essentially it's sepsis. And we all know that even in sepsis, you can have patients who have sepsis and they don't have a fever. So yes, it is possible that you can get a patient who is that sick and they actually don't have a fever. And in fact, on the contrary, they might have hypothermia instead. And unfortunately, those are the ones that tend to do poorly, especially when they get into critical care. Thank you.
Thank you so much. We're going to move on to our sponsors. We'd like them to say something short. We're currently sponsored today by AbbVie, and I'd like Anthony Zhao to say something as we move on to conclude.
Good evening. We have Monica Heda, and she will do a small presentation about sevoflurane. Monica.
Thank you, everyone. I'm not sure if you can see my screen as yet. Oh, and I'm not on the right side. Okay. So in terms of saving a little bit of time, I'm just going to go quickly over the clinical overview of sevoflurane and the main or important things. And I think first off, I just want to mention that AbbVie holds the registration for the one and only original sevoflurane on the global market. And this sevoflurane is indicated for induction and maintenance of general anesthesia in adult as well as pediatric patients, for inpatients, and then as well as outpatient surgery. So according to Delgado Herrera, the characteristics of sevoflurane includes the following. So there's the inherent stability, low flammability, non-pungent odor, lack of irritation to the airways, low blood gas solubility, minimal cardiovascular and respiratory side effects, minimal end organ effects, minimal effect on the cerebral blood flow, low reactivity with other drugs, and the vapor pressure and boiling point that enables delivery using the standard vaporization techniques. So if we look in terms of cardiovascular and cerebral profile, sevoflurane has a favorable cardiovascular profile. It is cardioprotective. It has a decreased risk of for creating arrhythmias during anesthesia. It has a decreased risk for myocardial infarctions, and it also results in greater hemodynamic stability. So therefore, sevoflurane's cerebral hemodynamic profile favors its use in the neuroanesthesia space. So it also has a cerebral vasodilatory effect that's more than what some of the older volatiles do have. Then it also maintains the ability of cerebral vasculature to respond to changes in perfusion pressure during anesthesia. And then Mehta et al. Stated that sevoflurane decreases the requirement for pharmacological and mechanical support and duration of stay in ICU and hospital, which is then ideal, and I assume what we all as HSPS wants at the end in the hospitals. Then if we look at the elderly patient, we know that older patients have 4 times more invasive procedures than some of our younger patients. And the elderly are considered as high-risk patients due to the high incidence of comorbidities amongst a lot of other things. And therefore, maintaining the hemodynamic stability in the elderly during anesthesia is crucial. So if we look at post-operative cognitive dysfunction, this is twice as common in elderly as in younger patients, and sevoflurane result in a higher hemodynamic stability compared to older volatiles. And then sevoflurane also has a larger molecular size, which aid in preventing POCD in the elderly. Then if you look in the pediatric space, we know that yearly millions of young children require anesthesia for surgery and other procedures and tests. And respiratory adverse events are one of the major causes of morbidity and mortality during pediatric anesthesia. So post-operative nausea and vomiting, as well as emergent delirium, are factors to be considered during the choice of a volatile anesthetic. And if you look at sevoflurane, it results in a minimal respiratory side effects due to less irritation to the airways than some of the older volatiles. It also has less risk of post-operative nausea and vomiting. And there is no increased incidence of emergent delirium versus some of the other volatile agents. Then just quickly in conclusion, as stated by Delgado Herrera et al., is that sevoflurane possesses a number of characteristics that approach those of the ideal anesthetic. So thank you everyone for attending this meeting, and yes, on behalf of AbbVie, have a great evening going forward. So back to the host.
Thank you. Monica is the medical manager based in AbbVie, South Africa. So 3 minutes, 4 minutes, Sarona Radley will also give us brief presentation on our sevoflurane.
Okay.
Sarona.
No problem.
Thank you. I just want to quickly share my screen. Okay. Thank you for the opportunity to speak to you. I would just like to give you a brief overview on the Altain value proposition. So Dr. Odaba mentioned during his presentation the exposure to a wide range of hazardous agents in the theatre. Now, from a occupational health and safety perspective, the continued exposure to high concentration of waste anesthetic gases may also cause health effects such as headaches and nausea, fatigue, and even more severe effects like liver and kidney disease. And it can even contribute to possible impaired fertility. Now, with Altain, Altain uses a quick fill system. In other words, it is a ready-to-use delivery system. No mounting of a separate adapter is required to fill your vaporizer, and this prevents the risk of spillage and leaking or evaporation of the volatile, thereby reducing the risk of anesthetic gas release in your theatre. So the bottle itself is made of polyethylene, ensuring that in case somebody drops the bottle, it will not break, as it is shatter resistant. And this reduces the risk of having to close your theatre due to hazardous spillage. AbbVie also continues a stable and regular supply of Altain as well as vaporizers into your facilities. AbbVie is invested in continued medical education, such as in-service training in an ongoing basis, and also educational investments such as the MEPA course in partnership with KSA and Kijaba Sim Center that was done last year. AbbVie is also involved in community projects and participates in the SMILE Foundation. In summary, AbbVie is a worldwide partner with Altain treating more than 1 billion patients, a 20 years of experience with a proven safety and efficacy profile. I thank you for your time.
Thank you, Sarona. Sarona is the key account manager as well based in AbbVie, South Africa. Thank you, Sarona.
Thank you. Thank you.
Thank you so much for that presentation. I'd like to divert your attention. Dr. Christian has shared a video on simulation and how to deal with COVID-19 patients. And last but not least, we are done for the day. I would like to thank you again for having me as your moderator. This is our last webinar of the year, and I'd like to hand over to our new chair-elect of the Kenya Society of Anesthesiologists, Dr. Steve Okello, to give us our parting shots. Thank you so much and good evening.
Thank you very much, Anne-Marie. Thank you all for attending this day's session. Mine is going to be really simple. It's just to express our appreciation as a society to all of you. I cannot mention all by name, but I must appreciate, first of all the participants. We've been having these webinars all the way from April till now. We are going to take a break till beginning of 2021. All the members of the Kenya Society of Anesthesiologists, thank you very much. All the non-members who have been joining us consistently across the other societies, all the people from Kenya, the bigger East Africa, the rest of Africa, and indeed the whole world. We've really enjoyed your company, sharing with us, our brothers from Uganda, Tanzania, Congo, Rwanda, Zambia, Malawi, South Africa, Nigeria, Somalia, Canada, India, the US, South Africa. We are really, really, really happy. And for the speakers all through, the people who have been able to share with us their experiences, their knowledge, asanteni sana. To the moderators, it's been a good job done. We thank you for taking your time and taking us through these sessions. To the organizers, the organizing committee within the Kenya Society of Anesthesiologists, bringing this together, to our administrator, Shelmith, great job done. We thank you very much. And to our sponsors, it's been a new experience working with you on this online platform. We learned a lot from this, and we'll see how best to take this going forward as we plan for the next year. We do welcome feedback from members, even as we are planning our calendar for the next year. Please share your feedback either on email, on WhatsApp, on whichever format you'd like us to move forward. This will be taken into account as we go on. Every cloud has a silver lining, and we can take positives from this COVID and see how we can maximize on this in terms of knowledge sharing, skills, and anything else that we need to share as anesthetists. Finally, I would like to wish all of us, I know almost all of us have been in one way or another affected by the COVID. Either you've been infected yourself, someone you know has been infected, or even passed on. We wish you quick recovery as you're going through this infection or being affected, the mental anguish of it and all that, and asking us to be our brother's keepers. Keep safe, all of you. Wish you all the best. Enjoy the rest of what 2020 has to offer. And with that, I'd like to bring this year's CME activities to a close. Thank you all for attending and for being attentive. And God bless you.
Thank you, everybody. Have a good night. You can find this and other recordings on the KSA YouTube page or their website. Good night. Good evening.